So we have a saying, coming together is the beginning, keeping together is the progress, and working together is success. And we know that after the success in Islamabad and in Lahore, we move on to a special team. I think this team is a team that actually builds mansions in deserts. I'm not sure if people have visited Gambut. It's sort of a village, but if you cross the bridge that actually takes you to Gambut Institute of Medical Sciences, it's like crossing the Mexican border from a village into a city. And I think this team is doing a great job in Gambut and doing a lot of transplants in people who are the well-deserving people. Before we move on to our next speaker, I would like to introduce our chairs. Fortunately, Dr. Abdul Wahab Dogar and Dr. Faisal Dar and Dr. Abu Bakr Hafiz have joined online. And again, these people need no introduction. Dr. Dogar is the one who's leading the team in Gambut. Dr. Faisal Dar is part of the team we already introduced with Dr. Najam, and now he's the head and dean at PKLI. And Dr. Abu Bakr Hafiz, he's doing liver transplants with the team in Shifa International. So we move on to our next speaker, Dr. Shams Zehri. He's a hepatobiliary transplant surgeon at Gambut Institute of Medical Sciences, and this is the team that has been working there and has surpassed all expectations from other people. So without any further delay, I would like to give the podium to Dr. Shams Zehri.
Thank you, Dr. Atif, and I'm very much thankful to the organizing committee for giving me this opportunity to share my views about this very important discussion, because the both options basically they are curative. Our intention is for the curation of the patient. So with this I would like to start my presentation. And at certain point it is quite obvious to decide either we want to go for the resection or we want to go for the transplantation. But there is an area where sometimes it becomes quite difficult to decide either we want to go for the resection or for the transplantation. So my major portion of the talk would be to discuss that area and to make a decision tool that which option would be better. So the contents which I am going to discuss one by one is, first of all, the epidemiology. Then I'll move on towards the prevalence of HCC among serotics and non-serotics. Then the HCC dynamics. Then the significance of child score, and then assessment of the liver volume. The role of IgG, especially when we are planning for resection, and the important three scenarios, one by one I discuss when we are sitting in our OPD and a patient comes, the three important scenarios which we see in our OPDs. And the treatment in non-serotics, what are the option modalities in them, and then the treatment in child B and C, and finally the gray area where sometimes it becomes quite difficult to decide either resection or liver transplantation would be beneficial for that patient. So the epidemiology, as we all know, that the liver cancer, it accounts around seventh most frequently occurring cancer in the world. And among these, the HCC accounts around 75% of the all liver cancer. So a major portion of the liver cancer, it makes a major portion. And then according to World Health Organization, according to the current estimated data, in 2030, if there 1 million people will die due to liver cancer. So around 1 million, I think the 8 million people will die due to hepatocellular carcinoma roughly. So a big reason to worry. And then the prevalence of HCC in serotics and non-serotics, we all know that when we are sitting in liver OPD, so commonly the most common HCC patients who come to us, they are serotics. So around 80 to 90% of these patients, they are serotics. So a major bulk, making the major bulk. And then around 10 to 20% of the patients, they come to our HCC, our OPD clinic, they are non-serotics. And this is the area which are usually ignored, or because they don't come to our OPD at the proper timing, and they are usually in a very healthy state, so they don't seek any medical advice timely. That's why when they arrive in our OPD, usually they are in a very advanced stage, and usually it becomes very difficult to have any curative options for them. So we should have any screening program for them as well. And then the dynamics of the HCC, we know that the prognosis of HCC patient is related to three main factors. One is the tumor burden and its aggressiveness, and the second important part is the liver dysfunction degree. And then finally, general condition of the patient, as in majority of the, it is very important to know that general condition of the patient. So only child score is enough to decide the management of a patient. So although child score is very helpful in saying that either it is child A, child B cirrhosis, but it is not the 100% scenario. It cannot 100% defines the treatment options in these. So ideally speaking, no, they are, because we need to look for the portal hypertension. Sometimes maybe the patient is child A, but the patient is having 40,000 platelets, so definitely you are not going to offer resection to this patient. And the functional liver remnant, definitely if we are planning for resection, we should know how much liver remnant will remain after we are going to perform resection in this patient. If we know that if the patient is cirrhotic, minimum future liver remnant should be more than 40%. And then technical consideration if we are planning for resection. Suppose a patient has an HCC in segment 6, so we know that in segment 6 lesion there you can do a wedge resection or minimum resection, but suppose if it is lying in the segment 5 and it is just causing compression over the portal vein and you have to go for the right portal vein, right hepatectomy, so definitely you have to think either this major resection patient can tolerate or not. And then, a very good data which says that there might be a occult lesion when you are planning for resection. Suppose you have found before resection, you find a single HCC in this patient, but after resection, this data says that 29% of the patient may show multiple HCC. So data was found after they did histopathological analysis of a patient, of the patients after transplant. What they found before transplant, they found that there was only one single HCC, but after histopathology, they found that there were multiple HCC. So if we are saying that we are going for resection, so definitely there is a risk that 29% of the patient we might see other HCCs after resection. So a very important role of ICG, we know that when we are planning for resection, the indocyanine green or ICG, it has a very important role in deciding either resection would be a good option in this patient or not. And then need to discuss the risk for development of the new lesions. Definitely when we are doing resection in a cirrhotic patient, we know that there are chances that in the future they might develop new lesions. And then lifelong medication and post-transplant complication while considering transplant. If you are offering a transplant to a patient, we should know that what the complications and related to the medication as well as related to the transplant can occur to this patient. And finally, the patient decision is also very important because our final goal is for the benefit of the patient. So if the patient agrees for a specific treatment, that also should be considered. And then the assessment of the liver volume, as I said, it has a very important role before deciding the management. That we have two types of assessment of the liver volume. One is the quantitative assessment and then the quality of the assessment. And the quantitative assessment, we have either CT scan or MR liver dynamic. So in the CT will only tell us how much liver is there. Suppose it is 1,000 gram or it is 600, 700, but we don't know how much functionally, how much the quality of the liver is, what is the quality of the liver and how much hepatocytes are there in between the fibrotic part. So that's why we need a specific quality assessments. For that we have indocyanine green, a very important dye which is useful if we are especially in the borderline resectable patients. The role of ICG, this slide will tell me about what are the different options when we have the ICG scoring system. If there is 10% at 15 minutes, we can proceed for trisectionectomy. If a dye is given and after 15 minutes you find in the blood there is less than 10% it remains in the blood, so you can plan for trisectionectomy. And if between 10 to 90% and 15 minutes, we can proceed for hemihepatectomy, but not more than that. And if 20 to 29%, we can go only for the segmentectomy, and 30 to 39%, we can do wedge resection only. And if it is more than 40%, then it means we can't do any resection and we have to think about liver transplantation. And this is a very good study in 2019 with the name of modified Mekuchi algorithm. I took this slide from that. So it includes two very important parts. One is the total bilirubin and the other important is the ICG. So definitely no ascites. So on the basis of this, if there is more than 2, the bilirubin is more than 2, we should never attempt resection. And the other important is again, which in my previous slide, the same things, less than 10%, we can go for the major resection. More than 40%, we can't do anything. And even if it is between 30 to 40%, few data say that resection is not a good option in these patients. So the three main scenarios, when we are sitting in our OPD, the patients which we might see, a patient with non-cirrhotic background, an HCC in a patient with a non-cirrhotic background. The other patient which we might see is a patient with child B or C cirrhosis, and another patient with child A cirrhosis. So we have to think accordingly that what should be the best option in this patient. So when we are seeing a patient with non-cirrhotic, definitely the surgical resection is the ideal treatment in that patient. And we should always think about that whenever it is possible. Even the majority of the patient, we can go for the major resection as there is no cirrhosis in the patient can tolerate a major resection, and even we can go for the IVC resection, we can go for the diaphragmatic resection in these patients, and we can go for the total vascular exclusion as well. The perioperative morbidity and mortality related to this non-cirrhotic patient, this is only 29%, and the mortality is only 2.7%, so very low mortality in these patients. And the post-operative survival rate is 96%, 87%, and 68% after 1 year, 3 year, and 5 year, which means a very good post-operative survival in these patients. And what about the tumor recurrence if it occurs in a non-cirrhotic patients? So tumor recurrence is the major cause of death in non-cirrhotic livers, and they usually don't have post-operative adjuvant chemotherapy. They have, but or are effective. They don't have a very effective post-operative adjuvant chemotherapy. And the recurrence rate in these patients is extremely high. The 1, 3, and 5 year survival is around 79%, 58%, and 54%. And finally, the good functioning liver, it can also allow us that we can go for a second resection, we can go for the third resection. So we have the option of resection again in these patients. What about the liver transplantation in these patients? So early studies, they showed a very poor outcome in patients who go for the for liver transplantation. The systemic review, they showed that from 1966, from 1988, they reported only 11% of 5-year survival. Another study showed that if the lesion is between 4 centimeter recurrence, in the reported a 40% recurrence rate for lesion 4 to 8 centimeter, and if it is more than 8 centimeter, around 78% of the recurrence rate. So on the basis of that, the International Consensus Conference recommends liver transplant in patients with non-resectable HCC, or they have experienced intrahepatic recurrence after surgical resection, provided these patients have no macrovascular invasion or extrahepatic spread. So what about the patients with child B and child C cirrhosis? We all know that definitely we can't do resection in these patients. So the only option remains, the curative option remains, is the liver transplant in this patient. So I think the only discussion is to proceed for liver transplant if they comes within liver transplant criteria. So the area which is very important to know is that child A, that is well-preserved livers. So this is the major portion which I am going to discuss. They actually have 1 year decompensation rate around 6%, and 1 year progression rate is 11%, and 1 year liver-related mortality is around 3%. And HCC in child A cirrhotics. So what are the options we have in these patients? We have the option of transplant, we have the option of liver resection, we have the option of microwave RFA, we have the option of TACE or TARE, we have the option of systemic chemotherapy, depending on the condition of the patient, and resection versus liver transplant. The other important part is it also depends on either their tumor is unifocal or multifocal, the tumor is within Milan or UCSF criteria or extended criteria, and the tumor location is again very important if you are planning for resection, and then the portal hypertension definitely, and the liver functions. So according to EASL guidelines for resection, they say when there is a solitary tumor, there is very well preserved liver functions like the normal bilirubin level and hepatic vein pressure gradient, it should not be more than 10 mmHg, and or the platelets should be more than 1 lakh. or the estimated liver remnant should be more than 50%, then we can plan for the resection in these patients. And patients who are not candidate for resection, if they're on invasive portal vein pressure measurement like HVPG, if it is more than 10, we should not think about resection. And the other indirect measures which can help us, the low platelet count, the splenomegaly, the esophageal varices, and plus the other parameters like if the bilirubin is more than 2, and we are planning for major resection, but there is a small FLR, and the ICG, if it is more than 40, we should not think about the resection. Why liver transplant as the main treatment modality in these patients in child A? Because we want to kill two birds with one stone, or we want to, that is no root, no fruit. So definitely if there will be no tumor and the cirrhotic, which is definitely the damage area, and plus the risk of developing cirrhosis, HCC in the cirrhotic area, so the patient will develop cirrhosis, HCC again in future. So we have different criteria for patients who are, we are planning for transplant, Milan and UCSF criteria. The pioneers of establishing a excellent criteria, that Muzaffaro et al. With the Milan criteria in 1996, they had excellent results, around 75% at 4 years and 83% at 4 years. Post liver transplant survival as well as the disease-free survival. Again, UCSF in 2001, they had excellent data. Even by increasing the size of the tumor, you can have excellent results. Why not to transplant beyond Milan criteria? The reason is that when they did a study and found that microvascular invasion was present in 11% of patients who were within Milan group, and around 42% of the patients who were outside the Milan group. So definitely a high risk of having microvascular invasion. And what is the importance of involving microvascular invasion? So definitely if there is 68% of the patients who have HCC recurrence, they after liver transplant, they were positive for microvascular invasion. So when there is a microvascular invasion, there is a high risk that this patient will develop HCC recurrence. So this was the, and another estimated data shows that the approximate risk of microvascular invasion. If the tumor is less than 2 centimeters, there is 10% risk of developing, having microvascular invasion. And if it is more than 8 centimeters, there is 45% risk of microvascular invasion. Again, if the alpha fetoprotein is more than 1000, there is 60% risk of having microvascular invasion. So a big reason to worry. And this is a very good article from a UCSF group in 2014 where they show that even the patient who are within Milan group and they have alpha feto more than 1000, so definitely they behave very badly. They have a high chances of recurrence. And plus the other important things you can see in this bar, that there is a alpha fetoprotein more than 1000, the survival without recurrence and survival with, so they had a high chances of recurrence. And again, there is a significance difference of p-value. Along with this, it also shows that there is high chances of vascular invasion in these patients. So if vascular invasion is that important, that how we can assess the vascular invasion? We have two kind of assessment. One is direct assessment. If there is macrovascular invasion on the CT scan, we can see either the vessels are involved or not, or plus we can go for the biopsy. And other important is we have the indirect means of assessing vascular invasion, that is by doing PET-CT. The study says that if recipients transplanted beyond Milan criteria who presented negative for PET-CT and alpha fetoprotein level less than 115, they show comparable results with the patients who are within Milan criteria. And liver transplantation in patients with hepatocellular carcinoma beyond the Milan group. As we know that from moving from the morphological criteria, that is moving beyond the tumor size and the number towards the biological criteria, that is inclusion of alpha fetoprotein, inclusion of the PIFCA2, and inclusion of the PET-CT has opened a way for us. So addition of alpha feto as well as the PET-CT along with the response to downstage, it has opened a way that we can think outside the Milan and UCSF group with excellent results. So this is a data which was from the Toronto group. They had excellent 5 years disease-free survival and recurrence-free survival. Even they had extended their tumor HCC confined to the liver only by adding alpha-fetoprotein, plus they also do pre-transplant liver biopsy, and if there is no poor histology, they go for the liver transplant with excellent results. Again, the Muzaffiro et al., the pioneer of Milan group, they also now extended their size of the tumor, and then they had excellent 5-year and disease-free survival and the recurrence-free survival. And now this is a very good slide which shows from moving from 1996 to 2020 and now 2022, you see that from that area the only criteria was based on tumor morphology and the Milan criteria, uses of criteria. But now at the passage of time, you can see it has having less significance as compared to the biological markers. Like we have now, in the beginning we had Milan and UCSF, now we are moving towards the Hangzhou criteria and then TTF and alpha-feto. They added alpha-fetoprotein and other biomarkers to make the results more good, even they extended their the size of the tumor. And now recently the response to downstage, this is also very important. If a patient responds to downstaging treatment, so then they have excellent outcomes. Now this is again a very good data which shows the liver resection versus liver transplantation, their surgical outcome. First of all, showing that intraoperative, the shorter operating time, less blood loss, technically it is less demanding, and early post-operative, their morbidity in resection is about 8 to 15%, whereas in liver transplantation it is around 21 to 30%. The donor morbidity is around 15 to 30%, whereas in liver resection there is no donor morbidity, of course, lesser bile leak as compared to the liver transplantation. And later they have early mortality less than 6 months and versus 5.5% in transplantation. And the risk of rejection and the risk of immunosuppressions, they are again present over there. Another very important article which says that liver transplantation versus liver resection for hepatocellular carcinoma in intention to treat analysis. They included 9 studies where 570s they had for liver resection and 861 for transplantation. And they found that the 1 year, 2 year and up to 5 year, their survival, they are almost equal with the liver transplantation. And the only difference they found that the 10-year overall survival was significantly lower in liver resection group as compared to the liver transplant. That is 29% versus 50% in liver transplant group. And the 1-year disease survival was similar, whereas the 3-year and disease-free survival was in liver resection was 54%, whereas in liver transplant it was 74%. So what about the role of salvage liver transplantation? And now we know that in the early periods of the time, the liver resection and liver transplantation, they have similar results. So then a new concept that is known as salvage liver transplantation came into existence. That it is defined as liver transplantation performed for recurrent HCC or deterioration of the liver function after primary liver resection. So then we have this option and we can go for this. So the background of salvage liver transplant, it was first proposed in 2000 by Majno et al. And then later on, early studies showed not good results because at that time they were not because of the technical reasons. They had very poor outcome, that is 28.6% much of mortality in these patients as compared to the primary liver transplant. And with the advancement of technique, now the results are excellent and comparable with the primary liver transplant group. What about the transplantation criteria for salvage liver transplant? Still, there are no clear-cut consensus built. But the different studies says, like this study says that if there is a tumor recurrence, it is within Milan criteria after resection. You do salvage liver transplant in this, they have excellent results. Another study compare it with the UCSF group, and they say if there is recurrence within UCSF group, the outcomes are not different as compared to the primary liver transplant. The only difference was there was a massive blood loss in salvage liver transplant as compared to the primary liver transplant group. So another study compare even the Hangzhou criteria and Milan criteria, UCSF criteria, they also showed similar results. So these were the studies which were conducted in the beginning, you can see from in 2003, their outcomes were not that good. 3 year was only disease-free survival was only 29. But now in 2013, if you see their outcomes become very excellent. So another very good data published in 2022, which says that salvage versus primary liver transplantation for hepatocellular carcinoma, a 20-year experience. So again, these show similar results, but because of the lack of time, I just want to skip it. Similar results, and they say that however, the salvage liver transplant group, the only difference was showed a slightly significant lower overall survival, 5-year survival. So these were the data, and their complication was also similar with the primary liver transplant as compared to the salvage liver transplantation. This 1 year and 3 year and overall they were comparable. So where we stand, our center, we are developing protocols for salvage liver transplant. Currently, we have changed our decision of liver transplant in 4 cases. Just 1 day before liver transplant and proceeded with liver resection in 3 and microwave ablation in 1, hoping that in the future we are following these patients, and 3 HCC cases follow-up period is more than a year in all 3 with no recurrence up to date. And 1 hemangioma case we did, as this patient had a huge hemangioma and FLR on the basis of pre-operative assessment was low. So we just made a plan that we will open it and see if we found the volume adequate. We go for the resection, and with resection on the background of complete liver transplant backup. So the patient recovered without any failure. So we also extend our criteria for primary liver transplant, as we are accepting patient with alpha fetoprotein even more than 1000. So we have done 2 cases now. If tumor, we have done 2 cases, but we have developed a special protocols for them. If tumor is not PET avid, if the PET CT, even if it is avid, it should not be more than 5. So then, or of course, no macrovascular invasion and no extrahepatic disease. So we have done 2 cases, and their follow-up is 6 months and 4 months. Still 3-month follow-up. We have done CT scan in both. There is no recurrence. Alpha feto is less than 10. So this is the last my summary. So if there is normal liver, we have, and the potential liver remnant is more than 30%, yes. So we have the option of resection in non-cirrhotics. And if the future liver remnant is not more than 30%, no, then we have the portal vein embolization option. Then again check for potential liver remnant. So if it is more than 30, go for the resection. If it is less than 30, no, we can't proceed for the liver resection. And what about cirrhotics? If cirrhotic child A, portal hypertension, no, potential liver remnant is more than 50, I think it is not working. It is not working. Yes. So yeah, then we have the option of resection, and if recurrence occur, we have the option of salvage liver transplantation. And what about the cirrhotics if the potential liver remnant is not more than 50%? So then we have the option of retain, that is ICG. So we have to see that either if the ICG is less than 14%, we have the option of resection. And then recurrence occur, we have the option of salvage liver transplantation. If the ICG is between 14 to 20%, the portal vein, we have the option of portal vein embolization. And then, again it stopped. And if it is between 20 to 40%, yeah, then we have the potential liver remnant is more than 50%, yes, then we have the option of resection. And finally, recurrence, we have the option of salvage liver transplantation. And if the potential liver remnant is not more than 50%, and no, we should not think about resection. Think about transplantation or other options. And if the ICG is less than 20%, no resection. And this is the last take-home message. Always downstage the tumor before transplant if situation allows to have good outcomes. And in LDLT, salvage liver transplant is quite justified option, need to be considered. Early outcomes of liver resection are not different than primary liver transplant. Therefore, there is room for salvage liver transplantation. Not only tumor burden, but behavior of the tumor should be considered, like pattern of AFP rise and PET CT if we are considering patient in extended criteria. And data suggest good outcome of patients even if alpha fetoprotein is more than 1000. So if PETs is added, but again we have to need local consensus, either we have to do it or not. But about the functional liver remnant in case of resection, it should be assessed. And borderline resection, risk versus benefit should be discussed with the patient. And to justify a policy, transplant patient with HCC beyond Milan criteria, the minimum expected 5-year post-liver transplant survival probability estimated by Metrotic calculator should be at least 50%. Thanks. Thank you.
Thank you very much, Shams. Very informative talk, definitely, to resect versus to transplant. In the setting of Pakistan, I think this is an important question where we've got limited transplant centers, donor issues, cost issues, and so many things going on.